All right. Dr. Ohl, if you want to take it away.
Yeah, hi, good morning. So for those of you from the media who are with us, this is also doubling as a briefing that we're going to put, that we're recording and that we're going to put, kind of like what we did a few years, for 3 years actually, during the actual pandemic itself. So what one of the first things I want to bring up that's different is that we're doing this by Zoom rather than in a dedicated media room. So we'll see how this goes, but I encourage everyone's participations and questions. So what I'll do is I'll probably talk for a while. As those of you who know me, usually I talk longer than what I think I'm going to, but I'll see if I can keep it directed on. And we'll talk some about COVID and what's going on now, but specifically what's different and what's different than what we had seen during the actual pandemic itself. And then we'll talk some about respiratory syncytial virus and a little bit about influenza and the upcoming cold and flu season and how best to navigate that. So first, let's talk about COVID. As I think most people are aware, we've been experiencing what I've been terming a wavelet of COVID over the last couple months. Started in the end of July, and then grew all through August. And our case numbers, while we don't count those like we did during the actual emergency phase of the pandemic, are pretty high. And I think most people know that anecdotally because they have had family or friends who've gotten COVID in the last month or so. The other aspect that tells us that our case numbers are high is monitoring wastewater numbers. And if you remember, this was something that we did during the first third of the pandemic. We started measuring the number of viral particles in our sewage. And from that, you can extrapolate a bit of where our case numbers are. Our wastewater numbers are pretty high right now. Actually, up here in the Triad, they're as high as they were during Omicron. When that original Omicron variant went through. If you maybe your PTSD will help you remember a little bit, but in January of 2022, when we had a huge explosion, a number of cases. The Charlotte area, the numbers aren't quite as high. If you want to compare them, maybe they're about as high as they were last January or February, which really wasn't a horrible time for our case numbers. And in Raleigh, they're kind of in between the two. Looking at our wastewater numbers across the state, most areas appear to be peaking or getting close to peak. And that kind of makes sense if you look at where our late summer, early fall waves were in the past. Usually by the time we got into mid-September, our numbers started to come down. And that's what I would anticipate would happen with this wavelet as well. What's different than prior waves? Well, the current cases that we're seeing are due to grandsons and granddaughters of that original Omicron variant that came through in early 2022. The one variant that people have been talking about, and we've been trying to keep an eye on, 2.86, if you're a numbers person, it doesn't really seem to be all that prominent in our area or in the state at this time. It's a little bit unclear yet how much of an impact that variant is going to have for us during our respiratory virus season coming up this winter and fall. But there are a little bit of flickers of hope that this variant may not be quite as transmissible, and two, that it doesn't cause any more severe disease than the other Omicron variants that we've been looking at. And that third is that it doesn't seem to be spreading quite as rapidly or fast is what would create a lot of concern for us. The one thing about that variant is that is a little different, is it has 30 some mutations. And so it may be a little bit more immune evasive. But the good news is we've just learned over the last week or so is that we still think that the upcoming specific booster that we're going to be having this fall should still protect from, particularly from severe disease and hospitalization. So what besides the numbers is really different from before? Well, first of all, as a population, 97% of us have either been vaccinated or have had COVID or both. And that incrementally creates immunity to the COVID, including all of the variants that we have circulating now. So if one does get COVID, the severity of the disease is going to be a lot less. And in fact, I think most of us anecdotally, when we talk about people we know who've gotten COVID, yes, we know people who've gotten symptoms and maybe have gotten ill, but they haven't landed in the hospital. And the symptoms usually go away after 3 or 4 days. And for most people, it's either a bad cold or even a mild cold. So this is how respiratory viruses fuse into the background of endemicity, and that's what's happening with COVID. We predicted it would happen all through the pandemic, and our predictions are coming true. It just continues to slide into endemicity. So because of the immunity that we have, and the fact that the Omicron variants aren't as severe as Delta and the original Alpha variants, we don't have the numbers in the hospital that we used to. While our numbers have gone up, and a number of people with COVID in our hospital have gone up, both in the Triad as well as in the Charlotte area, as well as in the Triangle, they're nowhere near what they were during the height of the Omicron original wave that happened in 2022. The other thing is that the number of people dying of COVID is almost trivial compared to what it was, for instance, during Delta, with Delta being the one that really slammed us hard as far as severity. In fact, the numbers of deaths that we've had through our health systems is roughly about 5% of what they were 2 years ago. So that's good news. And that's probably the one thing that really makes it different now, is that the severity of the disease is not what it was. And so hospitalizations and deaths are nearly what they were to this time a year ago or 2 years ago. And that makes the pandemic different, and it colors how we look at things. As this virus slides into endemicity and becomes more and more of a cold virus, the stakes aren't as high for us, which means what we have to do to mitigate or to protect ourselves doesn't have to be quite as intense as what it used to be either. And I think that's creating some confusion, because people see the case numbers up and they want to know, why isn't everyone masking again? Why aren't we doing social distancing again? And it's because we don't have to. And it's because as this virus gets more and more and more to be just the usual respiratory virus, what we have to do about it isn't going to be as extreme. So think about it. Do we haul out all of our masks when colds go around? Not necessarily. Even when flu comes up, we don't have to pull out a community mask standard or a mandate for masks in our schools. And so this virus is going to become similar to that. One other thing that makes it different now than what we had a couple years ago is that we have treatment, and we have pretty good oral treatment that'll keep people out of the hospital, particularly people who have other underlying medical problems or who are of older ages. And it works still very well. And it will work against all of the new variants that come down the pike from what we know. So far, COVID hasn't thrown a mutation that got around that med. Anecdotally, talking to my colleagues in and around the hospital, one other thing that's different about our hospitalized patients now is that they don't quite seem to be as sick. We don't have as many in our ICU, and those that are in the ICU tend to turn around quicker, respond to therapy faster, and that's also good news. Now, I don't want to trivialize because there are still going to be severe cases of COVID, particularly in people who are older, particularly those over the age of 70, those who are infirm, those with a lot of other coexisting medical problems, and also particularly those who are immunocompromised. And so we do need to be good citizens and help look out for these people. That means making sure everyone has an opportunity to get a booster vaccine and to get treatment early on in the course of their infection to keep them from getting into more severe disease and hospitalized, or one of the rare deaths that we still see. So that is, I think, in a nutshell, but in a summary, what's making it different now, even though we have a fair number of cases, is we have a large population-based immunity. And that's keeping us from getting into trouble with COVID. The numbers of hospitalizations are nothing what they had been in the past. And the number of deaths is really quite low compared to what they had been in the past. So as we move into the fall, what about some of those other respiratory viruses? Well, one of them that kind of gave us a bit of a pause last fall was RSV, respiratory syncytial virus. RSV is a virus that for most of us causes a cold, stuffy nose, bit of a sore throat, and then a cough. But for little babies and for people who are much older, it can be a much more severe disease and cause something called bronchiolitis in young children, which closes off their airways, usually kids under the age of 1. And then for older adults can cause pneumonia. And we're starting to see an increase in cases now in the Southeast. Here in North Carolina, we haven't seen it yet. Most of it's been in Florida and Georgia, but it's knocking on our door. And so we have a few things now in our toolbox for RSV that we didn't have last year. And one of them is we have a monoclonal antibody that we can give to little babies. And the ACIP said that every baby that's born should get that monoclonal antibody to protect them in their first year of life. We've also said that children who have underlying medical problems, particularly problems with their lungs, should get that monoclonal antibody up to through age 2 or so. And then lastly is there's going to be a recommendation out that pregnant women get that monoclonal antibody, because if they get it in their last trimester, they pass on those antibodies to their child and then protect them in the first few months of life when they're the most vulnerable. What about for the older adults? And what about for those with underlying medical problems? We now have an RSV vaccine that's been available since the middle of August. And those who are older, particularly those who are older than the age of 60, and those with underlying medical problems, especially in the lungs, should talk with their doctor about whether it's a good idea for them to get vaccinated. That vaccine is made not like our COVID vaccines. It's not a messenger RNA vaccine, but it's a recombinant protein vaccine, like we make a lot of our other common childhood vaccines. And it is protective, at least in the trials, we now know for 2 years for older adults, and keeping them out of trouble with RSV pneumonia. So I encourage people to talk with their physicians about whether they would be a good candidate for that vaccine. What about flu? Well, it's around the corner. We haven't seen it yet. It's a little bit hard to know these days what flu is going to do because flu and COVID have this odd relationship where they don't like being in the same room together for some reason. We still don't understand that 100%, but when COVID is circulating, flu doesn't seem to be, and vice versa. So we'll have to see how this season plays out. But flu vaccine is now available. You can get vaccinated with the flu vaccine at the same time you can with your COVID booster. But if you're considering getting the RSV vaccine, you might want to space those out because it does seem like there's a little bit more soreness and tenderness if you get that vaccine at the same time as others. Lastly, I wanted to mention we're going to have our COVID booster. It's just right around the corner. FDA and ACP meet in a few days here. And that booster is directed against the Omicron variants that were circulating in the early summer, which are still our predominant variants now. And it looks really on target for the variants that we're seeing causing this wave right now. We've all had a little bit of a wane in our immunity. Unless you've gotten COVID in the last 2 months, your immunity has waned from your last booster vaccine or your last vaccine series or from the last time you got COVID, unless it was in the past couple months. And so it's time to top off immunologically, so to speak, top off that immune tank, and that fall booster should do it. And so I really encourage anyone and everyone to think about getting that booster, and particularly those who are older than the age of 60 or so, those with underlying medical problems, those who are immunocompromised, should consider getting that vaccine. And lastly, anyone who doesn't want to get sick with COVID, and who wants to get sick anyway, because COVID will still take you out for 5 days where you have to stay home. I did want to mention a little bit, how are we going to navigate respiratory virus season coming up? So here's some pearls, I think, to think about. So if you get a cold, runny nose, sore throat, bit of a cough, maybe some headache, a little bit of aches, how do you know which one's which? Is it flu? Is it a cold, including RSV? Or is it COVID? Well, first of all, flu hits you fast. Usually you know roughly about what time you got sick. And people say, wow, I was watching Game of Thrones. I started it out and it was great, catching up on all those old episodes. And then by the end, I just felt lousy. I had a headache, I had a fever, my body hurt. I just didn't feel like getting out of the chair. That's kind of how flu hits you. It's very quick and sudden. It also will cause a sore throat when that happens, and some nasal stuffiness. But the systemic symptoms really predominate early on. And then as time goes on, the cough comes up. So that's flu. COVID, for most of us right now, starts as a runny nose, stuffy nose, bit of a sore throat, maybe a bit of a headache, maybe a fever in the first day or so, but a lot less than what we were having before. And one thing that's real different is we don't get the taste and smell perturbations as often. Early on in the pandemic, roughly 40% of people lost their sense of smell and taste. Now, recent studies show it's probably only about 7 to 10%. So COVID kind of looks like the cold for most of us. So how do you know? Well, the best thing is to test. So home tests are still available. You can still go out and buy them. Urgent cares have them. A lot of doctors' offices have them. Don't go to the emergency room to get a test for COVID unless you're really having an emergency. But get tested. And if that test is negative, then test again in a day or so. if your symptoms are continuing. If both of those tests are negative and you don't have the flu, then you got a cold. And you can go back to work, school, as soon as you start to feel better. If that test is positive, then you stay out for 5 days from the onset of symptoms. And then you go back to work, school for the 5 days afterwards, wearing a mask, being a good citizen to keep from spreading it. And if it's the flu, you got hit by that truck and you get tested and it's positive, then you can consider getting treated. We have good treatments for the flu. Shaves a couple days off of symptoms, makes the peak of symptoms a little bit less. So testing for that is worth doing. So that's a little bit, I think, how to navigate things as we go through the fall. I'd be happy to answer any questions that anyone might have. Hopefully I didn't put everybody to sleep.
Any questions, or if you guys want to post them in the chat, we'll take another minute or two.
I'll throw one out because I'm getting this question quite a bit now. Why aren't we going back to to widespread masking? And the answer for that is that we really don't need to. Those vulnerable people, the older people, those immunocompromised and such, they can protect themselves by wearing an N95, and everyone should be respectful. If somebody wants to wear a mask and not get COVID, then they probably have a reason. Another good reason to not get COVID is, let's say you have your daughter's wedding coming up in 2 weeks and you don't want to get sick for it. Wear a mask when you go out in the public areas for the 2 weeks beforehand. You can protect yourself. And because we can all protect ourselves, there's not a real reason anymore for the whole community at large to be masking all the time. It would have to get pretty bad again. Asymptomatic infections would have to be very prevalent again. And our hospital numbers would have to be going way up again. And so unless a new variant that really throws us a left turn in the future, I really don't see us having to go back to widespread masking. But anyone who wants to protect themselves, go for it and do it.
Looks like Richard Craver has a question. Richard, if you want to unmute and ask.
Yes, Dr. Ohl, you sort of answered the question I was going to ask you, but in the consideration of a third rail type of question, where do you see things like schools, hospitals, things like that? What would it take for that kind of masking, given how much pushback there probably would be, in particular with schools reintroducing masking?
Yeah, I think for a school to reintroduce masking, it would have to be that COVID, or really any respiratory virus for that matter, was really getting in the way of its mission. So in other words, you had a lot of teachers who were calling in sick, a lot of people out, so many kids that were having to stay home, the classrooms really couldn't function so well. If that came up to be the case, and so any respiratory virus had really slammed the community to that case, then masking could be considered again. Otherwise, I think it's based back to if your child has a reason to not get sick, they can wear a mask to go to school. But unless the school's mission or the workplace's mission was really getting interfered with, I don't think we would mandate it. Now, for a hospital, it's a little bit different because if you get a lot of people with respiratory viral crud coming into the hospital, either because of the virus itself or they're coming in for another reason, let's say they're coming in to have a baby, but they happen to have respiratory symptoms at the same time, then it's easier for the hospital to just say, okay, we're all going to wear our masks as healthcare workers all the time. And rather than try to sort and say, okay, that room we wear a mask, that room we don't need to wear a mask. Sometimes it gets confusing and we miss one. So we just say, you know, all the crud's really coming around, we'll wear masks in the hospital. So it's a little bit different for them than it is for other areas. You have a follow-up question?
Yeah, so actually two. One, and I should have asked this when I was talking about the schools. You know, there's been a push lately for companies to bring their workers back to the office, whether it's 2 times a week or full time. Um, do you sense any kind of potential pushback in terms of adults going back to work if COVID increases in a significant amount? And then the second question is, do you have a sense for how quick someone should be able to gain um, from the booster in terms of their waning protection that they would basically be as full as they could be again?
Yeah, so after the booster, basically you're immunologically topped off within 2 weeks. And it's going to happen faster than with the original vaccination because we're kind of waking up the immune system rather than having to create a new response. The second part of your question is coming back to the workplace. Again, it's kind of like I think it would be for schools. If the number of people in a workplace are getting respiratory illness to such an extent that it's getting in the way of things, then you can have them work from home. Or, for instance, if somebody tested positive for a COVID cold, but they still feel well enough, then they can work remotely and have their meetings that way, just like we did before, and then come back to the office after their 5 days are over. I mean, there are reasons for us to be together in the workplace that are separate and apart from the viral circulation as a whole. So I really think that we can navigate going back to the workplace during cold and flu season, just like we did before COVID. We just have to take into account that COVID's just going to be one of the viruses that circulate during cold and flu season, just like all the others.
Thank you.
Any other questions?
Must have done a good job doing a summary.
Well, thank you everyone for joining. Dr. Ohl, thank you as always. And if anybody has any follow-ups or needs the recording, just send me an email. Thank you.
Have a good weekend, everybody.